Hello, back again. I am Dr. Parvez Ahmad Rishi. I am MBBS and I'm doing MS now in ENT. And welcome to my presentation today. Today our topic is vertigo. Vertigo, the definition: it is a symptom and refers to perception of spinning and rotation of the person or their surroundings in the absence of physical movement. Guys, so remember, it is a symptom and there is feeling, there is perception of spinning or the rotation of either the person or the surrounding. So asking the first question we should ask: hey guy, hey patient, dear patient, what is spinning? Or you spinning, or is the surrounding is spinning? So this is the first question, is the beginning of the investigation of vertigo. And also it is the definition is, it is a symptom and refers to the perception of spinning or the rotation of the person or their surroundings in the absence of the physical movement. So there is no physical movement. Remember, there is no physical movement. There is spinning either of the person or of the surrounding, and it is just a symptom, and it refers to the perception of the patient. If we have peripheral vertigo, it has a labyrinthine cause. What is the labyrinthine cause of the peripheral vertigo? It is benign paroxysmal positional vertigo. BPPV is a labyrinthine origin and it causes peripheral vertigo. And peripheral vertigo, the labyrinthine cause, and the example is BPPV. Example is vestibular neuronitis. Example is Meniere's disease. So the three things we are going to discuss about the peripheral vertigo, the three subjects, the three topics we are going to discuss. These are from the labyrinthine cause, that is BPPV, vestibular neuronitis, and Meniere's disease. We will in the next coming up slides we will discuss three things, that is BPPV, vestibular neuronitis, Meniere's disease. In these diseases we have a peripheral vertigo, and that peripheral vertigo is from the labyrinthine cause. Central vertigo has a cerebellar cause. It is a common cause of central vertigo of cerebellar origin is migraine, or the migraine is the common cause of central vertigo. Then uncommon cause of central vertigo may be stroke, it may be TIA, it may be cerebellar tumor, it may be acoustic neuroma, it may be MS. So uncommon cause of central vertigo is stroke. Uncommon cause of central vertigo is TIA, cerebellar tumor, acoustic neuroma, MS. Assessment of vertigo. Most balance problems that present in primary care are not rotatory vertigo but unsteadiness. A full-time GP is likely to see 10 to 20 people with vertigo in one year. Guys, unsteadiness is the most common thing which we see in general practice, but the true vertigo only seen 10 to 20 times per year. So every dizziness, every unsteadiness is not vertigo. Most common causes of unsteadiness, these are functional or other, and they are not vertigo. That in reality we see only 10 to 20 cases of vertigo. To determine vertigo rather than dizziness, ask: do you feel lightheaded, or do you see the words spin around you as if you had just got off a roundabout? About timing, duration, onset, frequency, severity of symptoms. So guys, when patient comes to you, you ask him: do you feel lightheaded, or do you feel is world spinning around you, or like you had a roundabout just now? So we have two questions for the patient: do you feel lightheaded, is world spinning around you? Remember this thing. Patient comes to you, ask about aggravating factors. Example, head movement. How head movement is affecting your life? How head movement has affected your daily routine? Are you able to work in the hospital? Are you able to work in as a teacher? Are you able to work as a farmer? Is head movement giving you trouble? So is head movement an aggravating factor in the vertigo which you have? Ask about associated factors. Hearing loss. Do you have hearing loss? Do you have tinnitus? Do you have unilateral tinnitus, or do you have bilateral tinnitus? Do you have headache? Do you have diplopia, dysarthria, dysphagia, ataxia, nausea, vomiting? Elaborate, guys, elaborate everything. Ask about head movement, ask about tinnitus and headache. This is very important. Assessment of vertigo. Medical history. So a good history may lead to an early diagnosis. Recent URTI, ear infection, may suggest a vestibular neuronitis or labyrinthitis, and migraine, including likelihood of migrainous vertigo. If we ask the history of migraine, So, and we reach a diagnosis of migraine in the past or present, it may be a vertigo related to migraine. Head trauma, if there is any kind of trauma, if there is trauma to head or recent labyrinthitis, then diagnosis may be BPPV. Trauma to air, then it may be perilip fistula. Anxiety or depression can worsen symptom of cause feelings of lightheadedness. Example from hyperventilation. Alcohol, acute alcohol intoxication can cause vertigo. So we should take a good history, ask about URTI, ear infection, migraine, trauma, anxiety and alcohol. The examination includes five things. We go for an ENT examination. We do Weber, we do Rennes, we do full neurological examination. We look for the gait, and we particularly looking for the nystagmus. We look for five things, guys. In the examination of the vertigo, look for five things. Look for Weber, look for Rennes, do Weber, do Rennes, do neurological examination, see gait. What is the gait of the person, and what it do? What is the nystagmus? Is nystagmus present? Is it absent? Is it vertical? Is it horizontal? Where is the fast component? Where is the slow component? So see everything. Assessment of vertigo. Specific test. One is Romberg's test. Identifies peripheral or central cause of vertigo, but not sensitive for differentiating between them. Ask patient to stand up straight, feet together, arms outstretched with eyes closed. If patient unable to keep balance, the test is positive. Usually fall to side of lesion. A positive test suggests problem with proprioception or vestibular function. Hall-Pick maneuver to confirm diagnosis of BPPV. Hall-Pick maneuver demonstration. Be cautious with patient with neck or back pathology or carotid stenosis, as maneuver involves turning and extending neck. Ask patient to report any vertigo during the test. Keep eyes open and stare at examiner's nose. Sit upright on couch, head turned 45 to one side. Lie them down rapidly until head extended 30 degrees. Over end of bed, one ear downward, if neck problems can be done without neck extension. Observe eyes closely for 30 seconds for nystagmus. Note type and direction. Support head in position and sit up. Repeat with other side. Test is positive for BPPV if vertigo and nystagmus, torsional and beating towards ground, are present and nystagmus shows latency, fatigue and adaptation. Features of central causes of vertigo. Severe or prolonged, new onset headache, focal neurological deficit. Features of central causes of headache, vertigo. Severe or prolonged, new onset headache and focal neurological deficit. PNN, prolonged new neurological. Remember PNN, prolonged new neurological. Central type of nystagmus. Central type of nystagmus, vertical. Excess, nausea and vomiting. Prolonged severe imbalance, inability to stand up even with eyes open. So central type nystagmus is vertical. Excess nausea and vomiting. Prolonged severe imbalance, inability to stand up even with eyes open. Features of peripheral causes of vertigo. BPPV, vertigo induced by moving head position. Move head position, you have vertigo, this is BPPV. Episode lasts for seconds. Docky, I have a vertigo, I move my head. What is this? This is BPPV. Doki. It lasts for few seconds. What is it? BPPV. Features of peripheral causes of vertigo. Vestibular neuronitis, labyrinthitis. Features of peripheral causes of vertigo. Vestibular neuronitis and labyrinthitis. Vertigo persists for days and improves with time. No hearing loss, no tinnitus with vestibular neuronitis. In labyrinthitis, sudden hearing loss with vertigo and tinnitus may be present. So remember, features of peripheral causes of vertigo, vestibular neuronitis and labyrinthitis. What happens? Vertigo persists for days and improves with time. No hearing loss, tinnitus with vestibular neuronitis. In labyrinthitis, sudden hearing loss with vertigo and tinnitus may be present. Features of peripheral causes of vertigo. Meniere's disease. What are the features of peripheral causes of vertigo? In Meniere's disease, age 20 to 50 years men, greater than women, vertigo not provoked by position changes, episode lasts 30 minutes to several hours, symptom of tinnitus, hearing loss and fullness in air, maybe cluster of attack and long remission. So features of peripheral causes of vertigo continued. Now we are talking about Meniere's disease. Age in Meniere's 20 to 50. 20 to 50. Men greater than women. Vertigo not provoked by position. You change the position, there is no vertigo. Episode lasts 30 minutes to several hours. Symptoms of tinnitus, hearing loss, fullness in air, maybe cluster of attack and long remission. Medication used in vertigo. PCCP, PCCP, prochlorperazine, cyclizine, cinnarizine, promethazine. PCCP, prochlorperazine, cyclizine, cinnarizine, promethazine. Medication used in vertigo. PCCP. Thank you. Please like and subscribe so that I can continue putting more information so that people even sitting in bathroom can get knowledge about ENT and about AMC medical examinations. Thank you.